for the introduction. Perfect. So as you said, we'll be going over stroke prevention, recognition, and treatment. So there we go. So just a brief outline of kind of what I'll be discussing. We'll start with the basics of what a stroke, what exactly a stroke is, what are the signs and symptoms of a stroke, and then if somebody is experiencing a stroke and they come to the hospital, what to expect, what the kind of emergent stroke treatment and emergent stroke workup is whenever they get into the hospital, and then what can be done to both recognize a stroke and then try to reduce the risk of someone suffering a stroke. So first of all, just some basic facts about strokes and what they are and just how common they are. In the United States, every 3.5 minutes, someone dies because of a stroke. It's the 5th leading cause of death in the United States, and that's actually a recent update. Even, the causes of mortality in this country have shifted a lot since 2020. COVID jumped into the top 5, but stroke was 5th before COVID, and stroke was 5th even after COVID. So it still remains a leading cause of death in the United States, despite some upheaval in those statistics in the recent years. It's also the leading cause of long-term disability in the United States and worldwide. Interestingly, the incidence of strokes fell in the United States between 1995 and 2012. This is thought to be due to improvement in the management of cardiovascular risk factors, which is something that we know can contribute to the risk of developing a stroke. However, in that same time frame, the worldwide incidence increased by 70%. And this was primarily driven in a lot of lower income and lower middle income countries around the world. And just for a point of reference, worldwide, 1 in 4 adults over the age of 25 will suffer a stroke at some point in their lifetime. So it is an incredibly common medical condition, and unfortunately, an incredibly common cause of disability. So then, what is a stroke? So a stroke is due to interruption of blood flow to the brain, and because blood is interrupted going to the brain, oxygen is not being delivered to the brain. This leads to damage to the brain and ultimately death of the brain tissue. This is actually the same type of a phenomenon that happens in a heart attack. So another way to think of a stroke is that that it is a brain attack. And there are 2 major types of stroke, an ischemic stroke and a hemorrhagic stroke, as well as a TIA, which is a kind of a subcategory of an ischemic stroke, which I'll get into. But one thing that you see in red there, and that I'll reiterate throughout the talk, is that time is brain. Once blood stops flowing to the brain correctly, it's a timer until that brain tissue may become irreversibly damaged. And so the faster a stroke is recognized, the better likelihood that that damage the blood flow could be restored to the brain. So ischemic stroke is the most common type of stroke by a pretty significant margin. Almost 90%, 87% of all strokes are ischemic strokes. It's when a blood clot occurs in an artery of the brain that cuts off the blood supply of the rest of the brain beyond that clot. So ischemic strokes are ultimately a piping problem, where if the blood vessels are the pipes that bring blood to the brain, one of the pipes is blocked. And there are 2 main causes for why a pipe going to the brain might be blocked. One is an embolism and one is a thrombosis. So embolism is the medical term to describe a clot that came from somewhere else in the body. Typically, this is from the heart, though there are other rarer places that clots can come from. But so an embolism is when a clot occurs outside of the brain and goes into the brain. A thrombosis is when a clot occurs in the artery in the brain. So this is typically in the setting of damage to the blood vessels. That damage is called atherosclerosis. This leads to plaque formation in the artery, in the walls of the artery itself. And that plaque occurs slowly over time, and it can have acute clots form if damage to the plaque occurs. The most common causes, again, are atrial fibrillation. That's a condition in your heart that can, an abnormal heart rhythm that can make the heart more prone to form clots, which can then go to the brain via embolization. But then also high blood pressure, which is a risk factor for damage to the arteries, which can then cause the atherosclerosis that I mentioned, which can cause the thrombosis or the clot formation in the blood vessel itself. So if ischemic stroke is the most common, the less common is a hemorrhagic stroke. This is where an artery of the brain ruptures that causes a bleed into the brain. This bleeding into the brain will ultimately disrupt blood flow to the tissue, which will cause a stroke. So to borrow the plumbing analogy, if an ischemic stroke is a blocked pipe, a hemorrhagic stroke is a ruptured pipe, where one of the pipes unfortunately ruptures. And again, this is only a little over 10% of all strokes, so much less common. The most common cause in this case is high blood pressure. Again, that even borrowing on the plumbing analogy makes sense that if the blood pressure is too high, the walls of the pipe can only take so much pressure before they may rupture. However, there are other causes as well. Aneurysms, which are small outpouchings of the blood vessels, can rupture and cause a hemorrhage, as well as other rarer causes. Like AVM is one, but there are several others that are kind of rare congenital causes that may make someone predisposed to having a hemorrhage. And then the other thing worth mentioning is something called a TIA, or a transient ischemic attack. Colloquially, this is often called a mini stroke, and is where some of you may have heard that term before. So this is when a blood clot occurs and blocks blood flow to a brain. And because blood flow is blocked, a patient may have symptoms of a stroke, which we'll get to in a few slides. However, these symptoms occur very suddenly, but then resolve on their own, typically within 24 hours. And one of the hallmarks is that no permanent damage is done to the brain. But the concern is that these can be a warning sign of a stroke. So again, to borrow the plumbing analogy, this is where a clot forms and blocks blood flow to the brain. But for whatever reason, that clot dissolves on its own, so that blood flow is restored to the brain before any permanent damage. And again, it's reassuring that no permanent damage has occurred, but the concern is always that this may be a hallmark that someone may be at a risk of having a stroke, which could potentially cause permanent damage. So now I'm going to move on to what the stroke signs and symptoms are. It's incredibly challenging to say specifically what a stroke would look like, because it can vary person by person and stroke by stroke. In this sense, the signs and symptoms of a stroke are kind of like real estate, and that it's all about location, location, location. Depending on where the stroke is happening, that can determine what signs and symptoms that a patient may have. So some patients may have all of these symptoms. Some patients may only have one of these symptoms. Some patients may have very severe symptoms. Some patients have very mild symptoms. But in general, the symptoms that we worry about are listed here. So the first one, confusion. Again, difficulty understanding what is happening, can't thinking clearly, not responding correctly to questions or to things in their environment. Kind of paired with confusion is difficulty understanding. So this is more of a speech issue where they're having trouble understanding what is being said to them. They can even have problem getting the words out, like where they seem to be trying to find their words or using the wrong words to try to describe what they're saying. That can be the sign of a stroke. Dizziness, feeling very suddenly faint, lightheaded, or feeling like the room is spinning. Loss of balance, so this is where somebody suddenly can't walk right, feeling that they're wobbling, needing to support while walking, or can't walk in a straight line. It says suddenly numbness or tingling in the body, face, or arm. And for numbness, this is particularly if it's on one side of the body. So anytime we're talking about a stroke, it's most concerning if something is locked to either the left or the right side of the body, just because of how the brain is organized. So if somebody has numbness on one side of their face or one arm or one leg, that's potentially concerning as well. A severe headache, again, sudden acute onset. And by acute, I mean very sudden, like that onset of a headache, or a severe onset of the worst headache of their life, what sometimes is described as a thunderclap headache. That's pretty concerning as well, that somebody could be suffering a stroke. Then there's trouble speaking as well. Again, I already mentioned that on one hand, there's difficulty understanding, where it's a problem getting the words out, but trouble speaking can be that, but it also can be difficulty pronouncing the words, where they're slurring their speech, where the words make sense, but they're just severely slurred and difficult to understand. It can also be a problem with trouble walking. Like I said, this is similar to loss of balance, where they're able to walk in a straight line, or kind of falling into things. Also, if there's sudden vision changes, that's concerning as well. So sudden blurred vision or trouble with eyesight. This can be in one or both eyes. It's most concerning if it's only in one eye. Certain strokes in certain locations can cause difficulty with both eyes. what I always tell patients if they're having a visual symptom and they're not sure which eye it is, always make sure to cover one eye and then cover the other eye. That way you can see, is it only my right eye? Is it only my left eye? Or is there a problem with both eyes? Because that can be helpful as well. And then one of the hallmarks of a stroke is weakness. So this is weakness of the face, arm, or leg. And like I said, similar to numbness, this is most concerning when it's all on one side of the body. So all involving the right side or all involving the left side. That's again, with the way the brain organized, that is typically that's typically what we see in a stroke. And the one thing I didn't mention about all these signs and symptoms that's very key in a stroke is that all of these are sudden onset. These aren't symptoms that start and slowly get worse over a few days. These are symptoms that usually start like that out of nowhere. Because again, what's happening is that there is an interruption of blood flow to the brain, whether from an ischemic or a hemorrhagic stroke. And because of the sudden interruption of blood flow, these symptoms come on just as suddenly. So any of these symptoms that start very suddenly, that's very concerning for somebody, that somebody may be having a stroke. So what to do if you're concerned someone is having a stroke? A stroke is an emergency. Any signs or symptoms of a stroke, call 911 immediately. Okay. It's always better to call 911, even if someone is concerned, even if we later determine they're not having a stroke, because we'd rather have them get evaluated emergently to see if they are a stroke, because as I mentioned in the earlier slide, time is brain. If somebody comes in very quickly, there are sometimes some things we can do about a stroke. But if someone comes in, too late, then the damage may be already done, and there may not be anything we can do about the stroke. If somebody calls 911 because they're concerned someone has a stroke, a couple key things we always tell patients to tell the emergency medical services or the 911 responders in terms of what's going on is first the signs, the symptoms that made somebody concerned they're having a stroke, and then what the timing of those symptoms were. Both when did the symptoms start and when was the last time the patient was seen totally normal. Sometimes those are the same times where where a patient is with somebody else and suddenly the symptoms start and it's witnessed. But that's not always the case. Sometimes patients are found with symptoms when their loved ones hadn't seen them for a few hours. So knowing both when the symptoms were discovered and when the patient was last seen totally normal is very useful information for us to have when we're in the hospital. And then also medications that the patient takes, particularly any strong anticoagulations. These are strong blood thinners like Eliquis, Plavix, Xarelto, Coumadin or warfarin, or medications like Lovenox. It's also always good to know if a patient takes a baby aspirin every day. That's a very common medicine to take as well. So if somebody has 911 called and somebody is brought to the emergency room for evaluation for stroke, things are typically going to move pretty quickly. They're going to get immediately evaluated by emergency physician and then typically in consultation by a stroke neurologist. That consultation for a stroke neurologist may be in person. It may also be telehealth via a platform like Zoom, like we're using now, where a stroke neurologist may be remote, but video conferencing in to both get a history of what the symptoms were and the timing of the symptoms, as well as to do a focused stroke assessment via the video, which is something that has become more and more prevalent kind of throughout the country, is that telestroke assessment. But there will be a focused stroke assessment to look for the signs and the physical exam findings we expect to see from a stroke, as well as vital signs being taken and blood work being drawn. Then there will pretty much always be an imaging of the brain that is obtained. There are two main modalities we use to image the brain. One is a CAT scan or a CT scan, and the other is an MRI. The exact modality will depend on the emergency room you're taken to. The vast majority of emergency rooms in this country do use CT scanners. However, in some select circumstances or in some select emergency rooms, they may prefer MRIs. So that will typically depend on the actual emergency room somebody is taken to. So the entire point of coming to getting to the emergency room as quickly as possible and undergoing that stroke evaluation is to determine if a patient is eligible for stroke treatment. So as I said, the ultimate, and these treatments are aimed at treating ischemic strokes. Hemorrhagic strokes, the treatment is a little bit different. We don't have an acute treatment for hemorrhagic strokes because the blood vessel has already ruptured. However, for ischemic strokes, when there is a clot that is blocking blood flow to the brain, we do have some acute treatments that are aimed at dissolving that clot or removing that clot to restore blood flow to the brain. And there are two main acute stroke treatments that we have. One of them is a medicine called TPA. This is a very powerful clot-busting medicine. It's actually the same, it's a medicine that is made from an enzyme our body makes to dissolve clot, but this is just really, really high doses of that enzyme. The idea being that it will break up the clot that is causing the stroke. This is given through an IV. And this is again, to reiterate the time is brain statement, this is a medicine that can only be given within 4.5 hours from when the patient was last seen normal. And outside of that, it's just not as effective because unfortunately, like I said, time is brain, and patients who come in too late, some of that damage may already be done. However, there is an additional treatment that is called endovascular thrombectomy. This is a minimally invasive surgery where a catheter is used through an artery in the groin to actually go into the brain to manually remove a clot that is causing a stroke. This can only be done in the large arteries of the brain. It can't be done in some of the smaller arteries that are kind of farther along the pipes. This is only done if we can see that there's a big clot in one of the main pipes that's bringing blood to the brain. This does require, like I said, this is a surgical procedure, a minimally invasive surgical procedure, but a surgical procedure. So it does need to be at not all emergency rooms, not all hospitals can perform this treatment. Sometimes it does require patients to be emergently transferred to a hospital that can perform this treatment. And it typically does require intubation as well as a admission to the ICU for further management after the procedure. So speaking of after the procedure, what if a patient is determined to have suffered a stroke? They will always be admitted to the hospital. Patients who get TPA or thrombectomy, they will almost always require an intensive care admission. And again, to be carefully monitored for signs of side effects from those treatments, or for any worsening of their symptoms of their initial stroke. They'll be getting their vital signs taken very frequently, and very frequent neurologic assessment, again, to monitor for complications. If there is not any emergency treatment, patients are still very frequently admitted to the hospital. Sometimes to an intermediate care unit for more frequent checks, sometimes to a floor unit, and that just depends on the hospital themselves, the symptoms of the stroke, the size of the stroke. There's a lot of factors that determine where exactly a patient might be admitted to. But they are typically admitted and managed by both a medicine doctor, an internist, or a hospitalist, as well as a stroke neurologist who in the hospital. And again, they'll be having frequent vital signs and frequent neurologic checks, typically not as frequent as the intensive care unit, but still very frequent to monitor for deterioration or complications of their stroke. As well, in both settings, they typically have continuous cardiac monitoring. This is both to make sure that there's no abnormalities with the heart rhythm, but also to monitor for atrial fibrillation, because as I mentioned, atrial fibrillation is very common and a very common cause for patients to have strokes. Then, in addition to all of that acute care for somebody who's had a stroke, there will also be some additional tests that we do as part of the stroke workup. As I said, this is all to try to figure out why someone has a stroke. So as I said, the cardiac monitoring is to detect that irregular heart rhythm, that atrial fibrillation that is a very common cause. We'll also be looking at an echocardiogram, which is the ultrasound of the heart. This is to look at the function of the heart, to look for any structural or functional abnormalities of the heart, because we know that certain structural or functional abnormalities of the heart can make patients at a higher risk of having strokes. We'll also be looking for vital signs to see if patients have high blood pressure, which may or may not have already been diagnosed, as well as blood work to look for things like high cholesterol and diabetes or clotting disorders, which may put patients at a higher risk of having stroke. We'll also typically make sure that we have obtained full imaging of the blood vessels of the head and the neck. That is typically done on admission, but again, depending on the center, they may need to do ultrasounds of the blood vessels of the neck as well to look to see if there's major blockages in the neck. There's also typically a lot of stroke education that is done by a lot of the stroke nurse coordinators and the stroke team, as well as a rehabilitation assessment. So this is done by the therapy department, the physical therapist, the occupational therapist, and the speech therapist. Because as I mentioned, strokes can be quite disabling. That being said, we do know that stroke recovery is possible. Most of the stroke recovery occurs with both time and rehab. Those are the two things that we have available to us to facilitate stroke recovery. Unfortunately, we don't have any medications or any medical interventions to facilitate stroke recovery. It's really that time and therapy. So we have the therapists evaluate patients to determine what level of therapy is best for a patient to try to optimize their stroke recovery. And as well, that goes into discharge planning to try to determine what the next best step is for that patient, whether they can go home, whether they'll need to stay at a rehab hospital to work on their stroke recovery, kind of what's best for each patient. So having talked a lot about strokes, let's talk a little bit about how to reduce the risk of somebody having a stroke. One of the biggest things, one of the single largest modifiable risk factor for stroke prevention is blood pressure. We know that if there is, for every 10 millimeters of mercury or 10 points of reduction in the systolic blood pressure, which is the top number whenever somebody mentions the blood pressure, that reduces the risk of a stroke. Another way to say that is for every 10 millimeters of mercury increase in blood pressure, that increases your risk of stroke. So reducing that blood pressure, that top number in the blood pressure, is a very effective way to reduce somebody's risk of having a stroke. And we know that maintaining the blood pressure, that top number, the systolic number, less than 130, was associated with a 42% lower rate of stroke. So like I said, this is the single most important risk factor for stroke. And so that working with a patient's primary care doctor or sometimes cardiologist is very important to if somebody has a history of hypertension, to try to optimize their blood pressure regimen. This is typically done with medications and lifestyle management. And so right there are listed some common blood pressure medications that are used to try to manage patients' blood pressure. There's also we also know that cholesterol is a risk for having stroke. What we typically look for in cholesterol is the LDL cholesterol. LDL is the quote unquote bad cholesterol. This is the cholesterol that we know correlates to an increased risk in stroke. Again, for just like I mentioned with the risk of stroke, the risk reduction in stroke with blood pressure, if you can reduce your LDL by 40 points, it correlates to a 20% reduced risk of stroke. So if somebody has not suffered a stroke, there are different LDL levels that doctors look for to determine like what their ideal LDL level. However, once somebody has had a stroke, we actually know that an LDL less than 70 does significantly reduce the risk of having a second stroke. And that is what we typically recommend after somebody has had their first stroke. And so this is typically done with like blood pressure. Managing your cholesterol can be done with lifestyle modifications, but it is also very commonly done with medications. The most common medications are statin medications. These are medications like atorvastatin, which is Lipitor, simvastatin, which is Zocor, there's suvastatin or Crestor is the other common one. But there are other classes of cholesterol-lowering medications as well that that doctors may prescribe patients if a statin isn't enough, or based on individual patient factors. Another important stroke risk factor is blood glucose levels. We know that diabetes is a risk of having strokes. Glycemic control is definitely associated with is important to reduce the risk of stroke rather. We know that in patients with type 2 diabetes, having an A1C less than 7 was associated with a lower risk of stroke. So in patients who are diabetic, we do recommend glycemic control to reduce their risk of stroke. Other things that we know that we can do to reduce the risk of stroke are lifestyle interventions. The biggest lifestyle intervention that we have to reduce the risk of stroke is stopping smoking. We know that smoking increases the risk of stroke. It increases the risk of ischemic stroke and it increases the risk of hemorrhagic stroke. So we always recommend that all patients who smoke stop smoking. Even if somebody hasn't had a stroke, stopping smoking is one of the most important lifestyle modifications you can do to reduce your risk of having a stroke. And not only reduce your risk of having a stroke, but reduce your risk of other cardiovascular complications as well, like heart attacks or hardening of the arteries in your legs. Also, maintaining a healthy diet, low in fat, low in a lot of processed sugars, low in cholesterol, low in sodium. kind of the Mediterranean diet has been shown to help improve a lot of the markers we look for in reducing stroke risk, as well as the DASH diet to reduce cardiovascular risk, which are specific diets that there's a lot of information about available at various medical practices or even online, as well as regular exercise. 30 minutes of moderate exercise 5 times a week is what we typically recommend, as well as achieving and maintaining a healthy weight. And both of what I already mentioned, a healthy diet and regular exercise, already help to achieve that goal of a healthy weight, as well as taking steps to reduce somebody's stress. So in terms of the mnemonic we use as kind of to summarize everything we've talked about is, if you're trying to recognize whether a patient or a loved one or yourself has suffered a stroke, remember the mnemonic to be fast. B is balance, loss of balance or dizziness. E is eyesight, again, like I mentioned, the changes in vision. F is for facial droop, again, an uneven in smile or if they're slurring their speech. A is for arm or leg, and this refers to either arm or leg weakness or numbness. S is for speech difficulty, like I mentioned, trouble speaking, trouble getting the words out, not making sense. And then the T is for time. Like I said, you need to be fast. If you recognize the symptoms, call 911 immediately because time is brain. These are some additional resources, as well as the websites that you can find these additional resources at, both from Suburban Hospital, as well as from the American Stroke Association or the NIH, as well as strokeawareness.com. And these are just the references I pulled my information from, but I'll go back to this slide to have those references up. And at this point, certainly welcome any questions or comments.
Great. Thank you so much. That was, it's always, a good reminder for everyone to make sure that they know their numbers, their blood pressure is low, their cholesterol is low, and they're maintaining a healthy weight. So to avoid stroke. So we have one question. What does an MRI show as opposed to a CAT scan?
That's an excellent question. So both are different ways to image a person's brain, and not just the brain. You can get an MRI of a CAT scan of any part of the body. So the way I typically describe it is the CAT scan is like a Polaroid picture of the brain. It's a good picture, but sometimes it's a little fuzzy, and it doesn't have as much detail as we like. Whereas an MRI is a high definition picture of the brain. It gives us a lot more detail of the brain. Both have their advantages and disadvantages. The main advantage of the CAT scan is that it is very quick. You can get a CAT scan of the brain and the blood vessels of the brain in a few minutes, usually 5-ish minutes. So it's very quick. And it's also widely available and cheaper than MRI. And that's why it's typically the go-to imaging modality for acute stroke. MRI, as I said, is a much higher definition picture. MRI can actually give a pretty definitive answer on yes or no to stroke. They're based on certain, the way the MRI looks at the brain. We can look at an MRI of the brain and be able to tell pretty definitively if somebody has had a stroke. Unfortunately, the limitations with MRI is that it takes longer to get an MRI. So here at Suburban, we actually do use MRIs as our preferred method to screen stroke patients. And we work with the NIH and the experts at the NIH who are kind of experts in using this imaging to really refine how we do take the MRI of the brain. And we have a really fast MRI protocol to look for stroke. And that really fast MRI protocol takes 12 to 15 minutes. Other centers that their protocols, may take even longer than that. Typically, some centers take 15 to 30 minutes, and just to try to get like a very, very rapid MRI. So, and as I said, time is brain. So there's definitely, at some centers that time component that makes it not as ready to use in the acute in an acute setting when a patient is brought in with concerns of a stroke. And then the other problem with MRI is availability. The actual MRI machine is just more expensive to buy and maintain than a CAT scanner. So, smaller hospitals or standalone emergency rooms, they may not have access to MRI or even have access to MRI at all times of the day. For example, it's very common that patients can't get MRIs overnight because the people to run the MRI just aren't in-house overnight at some of the smaller centers. So that for those reasons, that's why CAT scan is typically done as the primary modality to screen for patients whenever they come into the hospital.
Right.
But also, to be clear, most patients, if they are admitted because they have had a stroke, they will typically get both, usually a CAT scan when they come in, but they will almost always get an MRI of the brain at some point in their hospitalization to both confirm the stroke as well as to look at the extent of the stroke, and again, to look at some other factors that the MRI can tell that a CAT scan just can't.
So if someone was out in the community and they were, in not near a suburban hospital, since we're a stroke center, would the what I guess this is I don't know if you would know, but the hospital, wherever they are, they would certainly do a CAT scan and an MRI just to confirm.
Yeah, so they typically would get the CAT scan in the emergency room. They would not necessarily get the MRI in the emergency room because, again, it just depends on the availability of the MRI. Not all hospitals have access to that, to getting very, very rapid MRI. And again, one of the purposes of these imaging is to determine not only if somebody had a stroke, but to determine if somebody is a potential candidate for those stroke treatments I mentioned. So a CAT scan is actually sufficient to tell if somebody is a candidate for the stroke treatment. So what ends up happening a lot is when somebody's brought into the ED, if they do not have access to hyperacute or very, very rapid MRIs, they get a CAT scan first to determine if they have a candidate for that acute stroke treatment, either the TPA or the thrombectomy. And then they'll get an MRI later on in their hospitalization after the treatment has already been administered.
Okay. All right. Perfect. Thank you. So, what is done about hemorrhagic strokes? Are there, and what are some, and how do you prevent a hemorrhagic stroke?
Yeah, that's a great question. So a hemorrhagic stroke is that we don't have as many acute treatments for the hemorrhagic stroke, because again, the problem there isn't a clot that we can dissolve or go get, but rather a ruptured blood vessel. And so there are different, and I'm not going to go into a lot of detail, but there are actually different types of hemorrhagic stroke, and that's mainly based on where the bleed actually is. There are kind of different areas in the brain that the bleed can be. So depending on where the bleed is, there may be some treatments that can be offered for hemorrhagic stroke, and these are all surgical treatments. The concern with hemorrhagic stroke is that if it is a severe enough hemorrhage, that a patient may require surgery. And that surgery there can be various things that the surgeries can entail. Sometimes if there is a ruptured blood vessel, sometimes they go in to try to close the rupture. Particularly with aneurysms, that's much more common if there's an aneurysm that's caused a hemorrhagic stroke. Sometimes if there's a lot of blood, it may require trying to go in and removing some of the blood, or even to try to relieve pressure on the brain. And then sometimes they may need to actually put in some drains in. Everybody's brain has a natural fluid-filled space, and sometimes that actually requires some drainage because of the extra blood that's in that space. So there are sometimes some surgical options that may be available to patients who have had a hemorrhagic stroke. As for reducing the risk of hemorrhagic stroke, so like I mentioned, one of the biggest risks of having a hemorrhagic stroke is blood pressure. So that's why I made the comment. Blood pressure is one of the most important modifiable risk factors, not only for reducing your risk for ischemic stroke, but also for reducing your risk of hemorrhagic stroke. So controlling that blood pressure, getting it into a healthy range, is definitely something we recommend, both for primary prevention, meaning preventing someone have one in the first place, as well as secondary prevention, meaning if someone unfortunately does have a stroke, ischemic or hemorrhagic, preventing somebody from having another one.
Okay. So you mentioned about, keeping blood pressure normal, low. So our next question addresses blood pressure. When I go to my doctor, my blood pressure is always high. And after being there for a while, and they retake it, and it was, so at first they took it, it was 159/70. And then they took it again, and after a while, and it was 129/59. Am I okay? And to that also, can you address the white coat syndrome? And why are there variables in blood pressure?
No, that's absolutely. And So that's absolutely something we know. White coat hypertension is a well-known phenomenon where patients go to the doctor and their blood pressure is higher when they're in the doctor's office. It's something we absolutely, and all doctors know that this is something that happens. So it's what you just described, that, you know, I'm rushing in rush hour traffic, I'm worked up, I ran up the flight of stairs, I get there and they take my blood pressure and it's 180. Well, you just were, for all intents and purposes, exercising to get there. But then you relax, you calm down, and your blood pressure normalizes. That's much more reassuring. Really, what we, in terms of blood pressure management when it comes to cardiovascular risk, so this isn't just for strokes, but even like heart attacks and as well. It's what your blood pressure is doing most of the time that is most important. So if your blood pressure is in the 120s most of the time, but it's 160 when you go to the doctor, that's not as concerning. If your blood pressure is 160 most of the time, but 180 when you go to the doctors, that's more concerning, because it's that most of the time blood pressure that really mediates your risk for heart attacks, strokes, both ischemic and hemorrhagic, and other cardiovascular complications. So what we typically recommend patients is that they actually monitor if there's any concerns about their blood pressure, they should monitor their blood pressure at home with a home blood pressure machine. Try to use the same machine. Not all machines are perfectly accurate. You know, a machine might underestimate your blood pressure, might underestimate your blood pressure. But if you're using the same machine the entire time, that slight inaccuracy will really not matter, because it's really what the numbers look like over time that matters. We also tell patients to actually vary what time they take it in the day, because if you always take your blood pressure in the morning, but it's actually at, you know, kind of lower in the morning and then creeps up during the day, you might not catch that. So, you know, take it in the morning sometimes, take it in the afternoon sometimes, take it in the evening sometimes. That way you can track what your blood pressure looks like at different times of the day over time. And that information is really helpful to provide your primary doctor, your primary care doctor, because they can look at those numbers, look at the trends of those numbers and say, okay, you know what? Yeah, it's 160 when you were here today, but I'm looking at your numbers and you're clearly 120 most of the time at home. And that's much more reassuring, as opposed to, yeah, you're 160 here today, but it looks like you're in the 140s, 150s most of the time, and that's a little high. Maybe there's something we need to do about that blood pressure.
Great. I remember that, like, in they had mall walking programs many years ago, and people would come and get their blood pressure on their right arm and their left arm, and, you know, before the exercise and after the exercise. And so this community is very well educated on blood pressure.
Yeah, absolutely.
It is wonderful. It's wonderful to know your numbers and how you're doing.
Yeah, no, absolutely. And like I said, it's really helpful. And one of the things that we ask patients, like if they have a stroke and we see them in follow-up, it's like, if you haven't been taking your blood pressure before, it's something to start doing. So it's something I recommend to anybody. I mean, I recommended my parents to start checking their blood pressure literally a couple months ago, because they had some of the similar questions. So I think if there's any concerns about what your blood pressure is doing, I think it's a good idea.
Yeah, agreed. Totally agree. It's they say stroke is a silent killer. So
exactly.
How does one diagnose a TIA?
Yeah, great question. So TIAs, as we mentioned, TIAs can look just like strokes in terms of their symptoms. In fact, that's one of the hallmarks of TIAs, is they look just like strokes. But one of the key things for a TIA is that the symptoms get better and go away completely on their own within 24 hours. And so that having sudden onset stroke-like symptoms that resolve on their own within 24 hours, that's clinically what we look for in a TIA. But again, one of the key things with a TIA, is that no permanent injury has been done to the brain because of the blockage. And that's where an MRI is very helpful. And any patient who comes in with a potential TIA, we always make sure to get an MRI on those patients. Because sometimes we do see, even though their clinical symptoms have gone away and they're feeling totally back to normal, there are these tiny spots on their brain that actually look like they have suffered some injury and have suffered very, very small strokes. Even though their symptoms have totally gone, the injury remains on the brain. So, you know, that's kind of a very subtle distinction, but even in those patients where their symptoms are gone, but we see something on their brain, we do say that they have suffered a stroke, because we do see it. But there are patients that their symptoms totally get better, totally go away. We get their MRI, there's no damage on their MRI, those are the patients where we're like, we think you probably had a TIA. And, even though there was no permanent damage, we treat TIAs just like we had to treat strokes. We, in terms of medications to prevent strokes in the future, managing risk factors like high cholesterol, diabetes, hypertension, we still recommend all of those things to TIAs to try to prevent a stroke in the future.
Perfect. Thank you. These are some great questions. Here we have two more. Does an MRI require contrast to check for a stroke?
Great question. No. So an MRI does not require contrast to check for stroke. The CAT scan does. So the CAT scan, you do need contrast in order to, it's not actually to check for a stroke. What you need the contrast for in a CAT scan is actually to look at the blood vessels. So because I mentioned one of the possible therapies is the endovascular thrombectomy, where we, a minimally invasive surgery to take a clot out of one of the large vessels in the brain. Though in order to do that, we need to look at the large vessels of the brain, and that requires contrast on a CAT scan. Interestingly, it actually does not require contrast on an MRI. We can actually get the same blood vessel imaging without contrast on the MRI. And that's because of very complicated physics, which I'm going to be honest, I need to start using, in order for me to explain why you don't need contrast on an MRI, I have to start breaking out the math. And I'm not even that great at that math. And I'm sure if I start breaking out equations, everyone's going to just leave just out of sheer boredom. But the MRI, you actually do not need the contrast to look at the blood vessels. That being said, there is a utility in contrast even at the MRI. For some patients, there's some very advanced imaging that we can use that's called perfusion imaging. This is advanced imaging that actually looks at how the blood is getting to the brain, not just whether there's a blockage or not, like the CTA. And we can do that perfusion imaging both with MRI or with CAT scan, but both perfusion imaging requires contrast. And so certain patients in certain situations do get that perfusion imaging. Quite honestly, a lot of centers are starting to include perfusion imaging regularly because they do just provide more information about whether somebody's having a stroke. And as I said, it's actually looking at how the blood is getting to the brain, which is very useful in a stroke setting. So it's becoming more and more common that even places that can't do thrombectomies or don't have an MRI, they may be doing perfusion studies with their CAT scans and giving the contrast for it. So that is something that is becoming more and more common. And again, if somebody is brought to the emergency room with concerns for a stroke, they very well may get in today's current stroke landscape.
What is the reason for many strokes occurring immediately from a head injury due to a fall?
That's a great question. So that one's really tough, and it's sometimes really even tough to differentiate this. Are the symptoms of a stroke because of the fall, or did the symptoms of the stroke cause the fall? Because again, one of the symptoms of a stroke is difficulty walking or weakness on one side of the body. So did they fall because they had weakness on one side of the body, and that's why they fell? Or did they fall and hit their head and suffer a concussion or a minor brain injury that caused stroke-like symptoms because of the injury? That can be really challenging to assess. It can be really challenging. And that's where, again, some of those imaging modalities can really help out. Things like an MRI to look to see if there's any permanent injury to the brain. The MRI is also really useful in looking for things like TBI, traumatic brain injuries from falls, because it can really help kind of tease that out. But and sometimes, if they get an MRI and it's totally normal, no stroke, no injury, that can be really tough to say, to determine what was the chicken or the egg. Was the fall that caused the stroke symptoms, or did the stroke symptoms cause the fall? What we typically do is treat both. Treat them like they had a TIA, just because, again, we want to try to, if it was a TIA, we just want to try to reduce the risk of having a stroke in the future.
Great. So if there is a clot in the brain, is a stent used?
That is a great question. And so the answer is no. And this is counterintuitive because stents are used everywhere else, right? People get stents in their legs, people get stents in their heart. they've done trials looking at stents in the brain because it makes sense, right? It's an artery in the brain, just like if there's a blocked artery in the brain, in the heart, they put a stent in. Or if there's a blocked artery in the brain, you should put a stent in. But as it turns out, when in the trials that have looked at stents in the arteries of the brain, those stents have not actually reduced the risk of a recurrent stroke. In fact, in some of those trials, patients who had stents in the brain did worse than patients who did not have stents in the brain. And we don't fully understand why. It's definitely something that's unique to the blood vessels of the brain, that stents do not seem to be as effective of a treatment for those blockages in the blood vessels as anywhere else in the body. So that's why stents are not routinely used in stroke care in the brain. There is an exception to that rule, and that's if the blockage isn't in the brain. So if there's a blockage in one of the arteries in the neck that goes to the brain, we do know that stents in the arteries of the neck can help reduce the risk of stroke. So if it's a blockage in the artery of the neck, stents may be used and are very commonly used if it's a severe enough blockage. But in the brain itself, we do not routinely use stents.
How well do post-stroke therapies work? And can the vessels in the brain and/or neurons repair themselves?
Yeah, that's a really great question. Stroke recovery is a complicated thing, and it's an evolving field. Just like stroke care and the treatments we give to acute stroke patients has evolved within the past 5 years. Stroke recovery is also an evolving field. So I'm going to start by answering the second part of that question first in terms of recovery. So unfortunately, when someone has suffered a stroke and there's been damage to the brain, that damage is permanent. It leaves a scar on the brain. The neurons that have been damaged by the stroke do not repair themselves. The brain is unfortunately one of the worst organs in the body in terms of its ability to heal itself. If there's injury to the heart or to a certain extent, or to injury to things like the liver or the kidneys, those organs can have the ability to repair themselves to a pretty impressive degree sometimes. The brain just does not. The way that stroke recovery works is that undamaged areas of the brain that have not suffered a stroke, actually learn to do what the damaged areas were doing before. So for example, if somebody has weakness in their right arm because of their stroke, because the stroke has damaged the part of the brain that deals with their right arm, other parts of the brain that weren't moving the right arm before learn to start to move the right arm. So in terms of how well post-stroke therapies work, it unfortunately really depends on a lot of different factors. One is, of course, the stroke itself. How big was the stroke? Where was the stroke? What is the underlying brain health of the person? Is this someone who's had strokes before? Is this someone who has underlying dementia or other central nervous system or brain conditions that may limit their ability for their brain to recover, for their brain to learn to do those new things? That may limit the patient's ability. Also, age plays a big role. Younger brains are just better than older brains in terms of their ability to recover and ability to learn those new things. So unfortunately, I can't give a nice, one single answer to that because I think it is so varied. But like I said, we do know that in terms of the actual therapy, that therapy certainly does help recover from stroke, especially within the first 3 to 6 months is where most of that that benefit from therapy seems to be clustered. So that's why we do recommend that stroke patients participate in therapy after their hospitalization in the medical hospital to try to optimize that recovery.
Wow, that was just a lot of good information. I had one more question. One question. So I have known people that were very sick with other conditions, cancer, for example, and then they didn't die from the cancer, but they died from a stroke, and it was so severe that it rendered them incapacitated. Is there a reason for that, or is that just like the body's deteriorating and there's therefore a stroke, or is there another reason?
Yeah, so that's a very a good question, and so that's actually a very specific situation that we do know information about. So cancer itself, certain cancers can actually make the blood sticky and more prone to form clots. and those clots can actually go to the brain and cause stroke. So I mentioned before that one of the causes of stroke is embolism, where a clot forms somewhere else in the body and goes to the brain. The heart and atrial fibrillation is one of the most common causes, but cancer is actually another cause of that. So in the case that you mentioned, we actually do know that cancer itself, particularly certain types of cancers, are actually carry a risk of having that tendency to form clots and therefore having a tendency to have strokes with them.
Okay. Well, I don't want to end on that note, but I just thank you again, Dr. Beaker. I appreciate your willingness to be here and educate us. If there are any other questions for our speaker, please put them in the Q&A box. And we'll answer them. But I really appreciate your time here, and also Dr. Adil's time. Hopefully there were no patients in the hour that we've been here that needed
Nope, the pager didn't go off while we were here.
It didn't go off. Okay, good.
Yeah.
But thank you again. And I appreciate your time and your expertise, and best of luck to you on your graduation from fellowship. Maybe we'll see you around in the hospital walls. But thank you again, everyone. And we'll see each other next time in July for the next webinar. So have a wonderful rest of your day. Arlene says, good program. Thank you. Lots to figure out and learn. I have to be fast on my refrigerator. The be fast. Okay. One last question before you leave. What is the difference between an aneurysm and a stroke?
Yeah, great question. So an aneurysm is when there is a small outpouching on a blood vessel. Hold on, I'm actually going to go back a few slides. Give me one moment, because I believe one of them had a picture. Yeah, so this, I don't know if you guys can see. Can you see my mouse? Okay. So you see here, this is one of the blood vessels in the brain, and you see this is a little outpouching from the blood vessel. So this is what an aneurysm is. It's where there's a small outpouching from a blood vessel. So aneurysms can be a risk of having a hemorrhagic stroke, where these aneurysms sometimes can rupture, which again causes a rupture in the pipe, which can cause a bleed and a hemorrhagic stroke. So that's how aneurysms and strokes are linked. Not all aneurysms rupture. Some people have aneurysms that just get monitored and they never rupture. But there are certain features of a particular aneurysm that make them high risk of having rupture. Certain other factors. Again, it all comes back down to blood pressure. If somebody has an aneurysm, one of the biggest risks for its expansion and rupture is blood pressure and smoking. Those are two major risk factors for having aneurysms that rupture. But some people have aneurysms their entire life, never have any symptoms from them. Some people do. Some people never know they have an aneurysm until they have a bleed, unfortunately have a hemorrhage from the aneurysm. So currently we don't recommend routine screening for aneurysms because they're not very common in the population. However, if somebody does have an aneurysm that's picked up on some incidental imaging before, and they've never had a stroke, never either hemorrhagic or ischemic, there's something that we typically just keep, depending on the features of the aneurysm, keep an eye on. And again, in certain cases, these are typically followed by neurosurgeons. And in some cases, the neurosurgeons may actually recommend doing something about the aneurysm to try to prevent it from rupturing rather than just watching it. But that's very case by case. It depends on the aneurysm. It depends on the patient. There's a lot of factors that going into making that recommendation. But like I said, we don't routinely recommend that patients get screened for aneurysms.
Perfect. Okay, well, with that, I appreciate it again. Thank you very much. And we'll see each other again, and have a wonderful rest of your day. Thank you again, Dr. Beaker.
Of course. Thank you for having me.
Bye.